Hi, everybody. First of all, I'd like to thank Salia for giving me the opportunity and permission to address you, not in person. These are extraordinary circumstances. We're at war. The airlines have canceled their flights to and from Israel, and I'm stuck here near Tel Aviv. And I really wish I could be with you in Bristol, especially because oral malodor has been something, shall I say, close to my heart for over 3 decades. And before I start, a great big shout out to John Greenman and Salih Assad, uh, true pioneers in this area. It's been a great honor and privilege for me to have worked with you for, wow, over 20 years now, maybe 30. And I salute you both. And to the other people at the meeting, I don't know who is coming, but you know who you are, and a great big thank you for keeping the flame of bad breath research alive. I thought I would share with you something a bit weird that has happened to me since Corona. It's not necessarily scientific, but it is, I think, important at least to discuss. And if you'd like to challenge me, I'd be very happy. You can reach out, message me as you will. And what I'm going to talk about today is the weird subject of advising, consulting for bad breath over the internet. It's not something that I intended to do. It just happened when Corona hit, and it was impossible and probably uh, not very clever to stick my nose into other people's mouths as we had done for several dozen years. So I had this idea: would it be possible to help people over the internet, over Zoom? And I gave it a try. Somebody phoned me. Can I consult with you? And I said, look, everything's shut down. I'm not leaving the house. I'm not smelling anybody's breath these days. But if you have somebody, a partner, an adult, a confidant, who's willing to go on Zoom together with you, then I will be happy to try and consult you over the internet. And that's the topic of my conversation. Since then, I've had probably between a dozen and 20 consultations like that over the internet. And I think that the potential is there. Well, let me tell you how it works. So, for many years, one of the problems of having a bad breath consultation clinic is that you don't really know who has measurable bad breath, odor that you can test and smell, and people who are coming in with no observable bad breath or very little and huge exaggeration on the terms of the person who's complaining about the problem. So many years ago, I had this idea, well, unless somebody else, an adult in the family or a friend, is complaining and you come into the clinic together, I don't want to consult with you because I've had so many cases of people who come in and leave very disappointed because I haven't found the bad breath that perhaps wasn't there to start with. When you're doing it in a clinic and people say, yes, I'm going to come in with my husband, and they come in without your husband, what are you going to do? You have to accept them. And very often you are not able to supply the goods because when you try and smell the odor, there is nothing there. So I said, okay, what would happen if I used the confident as the odor judge? So this is how it works. I asked both of them to come on a Zoom. The person complaining, and another adult in the family, brother, a spouse, a partner, and I explained at the beginning that I'm not a physician, I'm not a dentist, I'm a PhD. So this is a kind of a scientific consultation. I'm trying to help. I don't promise I'll be able to help, but I do have expertise in this area. And if they're willing to cooperate, perhaps at least we could do some of the diagnosis over Zoom and then let the physician or dentist continue with potential treatment. So the moment that both of them agree, we can get started. The first step, it's almost like in the clinic. Um, Anamnesis, take a history. How long has the problem been going on? What's it like? When is it worst? What other complaints does the person have? Keeping in mind that bad breath is not a medical condition. It's a condition, but health condition perhaps, but not medical. So focusing on the bad breath side of it, I'm not a person to give medical advice, that's for sure. Um, and after that, I do what I've been doing in the clinic for over 30 years, which is to ask the person to count aloud to 20, because we find that the percussion in speech enables the breath to be more readily evaluated. And then to ask the other person, the confidant, to smell and to tell us whether this is the odor that is the regular odor coming out of the mouth. This is really super important because to get to the root of the problem, you want to establish that this is the characteristic odor. As I've mentioned time and again, there's all kinds of different odors coming from the mouth, from the nose. We want to find the characteristic one. Are we interested in the level of the odor? Not that much, really. Because if it bothers the person living with the person, then it doesn't really matter if it's a 4, a 2, a 2.5 on the 0 to 5 scale. That is of less significance than whether there is an odor and whether it's coming from the mouth when the person counts aloud to 20. The next stage is very important. This is something that has been known for over a century, that it's easy to separate the different kinds of odor. We ask the person to shut their lips and breathe out through the nose. Okay? Is the odor coming from the nose and not the mouth? Is the odor coming from both the mouth and the nose? And is it the same kind of odor and at about the same level? And that helps us give a really good diagnosis, because if the odor is coming from the mouth and not the nose, then it's an oral or pharyngeal problem. If the odor is coming from the nose but not the mouth, connected to the upper nasal passage, isn't it? If the odor is coming from the mouth and the nose at the same time, then it's coming from the lungs if it smells similar. And that may be from something in the bronchi, in the lungs, in some other part of the body, some systemic illness, but these are very rare. I haven't seen one in these Zoom consultations. Of course, it's usually from the oral cavity. 85% or 90% of cases are. Okay, now is the stage where we want to identify where the odor might be coming from. So since the 1990s, together with the Frat Lab, we started using a spoon rather than gauze to sample the back of the tongue. You remember we once had a paper on the front of the tongue, the wrist lick test. That wasn't very good. I won't go into the reasons. This one is much better because, as Grapp showed over 90 years ago, can you imagine, in the 30s of the previous century, most odor comes from the very back of the tongue. And what we've been doing for many years is instructing people to take a sample from the very back of their tongue, about 12 centimeters back. That's where the odor, most of the odor comes from. And at every meeting, I do this demonstration, so I'm going to do it now in the comfort of my own home. Ready? Okay, not pleasant. But we ask the person to do this, and usually they're quite successful. And then we give the spoon to the confidant, to the other person who's together with the person complaining. Is this the character of the odor? You know, odor from the back of the tongue, including this, has its own distinct odor. I'm not the person to tell you whether it's more nitrogen, more sulfur, perhaps Salia and John can, but the odor is distinct from the classic odor that you get from floss between the teeth or something that's a probe. A different kind of odor. And if the other person says, yes, this is the odor coming from the spoon. This reminds me of the odor coming from the mouth. We've solved half of the problem at least. Of course, if the odor is coming from the nose, straight to the ear, nose, throat specialist. And if the odor is coming from the mouth, but maybe not sure about the spoon, then my suggestion is in countries where you're able to buy a chlorhexidine mouthwash, not as a drug, but over the counter, and if you're able to gargle once or twice a day for a week, as a diagnostic tool, not as a therapeutic, just to see whether the odor goes away or not. And in many cases, this works. One of the great things that it does is it enables me not to see people that I cannot help, people who have just a complaint of oral odor, but nobody to confirm the oral odor before they come to the clinic. It provides a solution for people that are abroad and don't have a clinic they can drive to. And so far, the results seem to be pretty good. The problem is, of course, that somebody has to do science. I'm retired, and I'm not going to write a paper on this. But for those of you who are checking bad breath and are active in the field, I want to suggest it as a possibility in cases where you want to avoid patients coming in who have just a complaint, or because of infection concerns, or because the people are far away from a clinic, and I'm sure that there are many reasons. And again, it avoids the problem of self-estimation. Back in the mid-90s, together with Ilana Eli, we showed that people complaining of bad breath are very subjective when it comes to scoring their own bad breath, into trying to know how bad it is. And that is not because they cannot smell the odor. They can't smell the odor, but they have trouble scoring the odor because they are influenced by their own preconceptions. Perhaps not surprising in retrospect, but we were very surprised when those results came out. So since then, that's of course very interesting to hear the story of somebody complaining about bad breath, but people with bad breath are usually not objective reporters. And we need the confident, we need somebody else to vouch for them. Now, when this somebody else is someone who lives with them, well, it's the best. Even going forward, a year from now, half a year from now, the person has bad breath. I've trained the confident how to compare the odor from the mouth and from the nose, how to check for back of the tongue breath. And I feel that this is potentially a possible approach to helping people beyond the clinical research that we did for so many years. I'll just add that since the mid 80s, we have had people come into the clinic and ask us to help them with their bad breath. And rather than look at this as a kind of a nuisance, we learned from the people coming in. And then I was able to open a clinic with various dentists and smell thousands of people. And I think that my expertise grew as a result of trying to help people in the field. It's great when you have some basic applications in the lab and you can apply them to try and help people that have a condition or problem. So I think that I'm going to stop there. I know it's a peculiar approach, and I'd like to ask you to consider it and to reach out with questions, and I will try to address them. And if somebody does research on this, wow, I'll be so delighted. Wishing you all a wonderful conference, and at least I've been there in spirit. Take care, everybody.